Assalamu alaikum. Good morning, good afternoon, and good evening, depending on your time zone. I hope everybody is doing great. Let's move on to the third lecture of today's crash course. Buckle up, it's going to be a little bit long. I hope it's not boring, but it's going to be for sure a little bit long, but they're important. Movement disorder. So, movement disorder is very commonly tested in NACOSKI and MCQ1. So, in NACOSKI, probably you get a station which you have a patient who has problem with movement, or probably the patient is there accompanied by somebody else who has Parkinsonism. Basically, you need to do some maneuvers, special tests to see if the patient is having a proper gait, if the patient has any, for example, movement disorder, for example, tremor, how to check for that, how to do the posture, how to do the kinetic test, how to do for the balance, how to do the check for the pull test, all this, because you need to find out the movement disorder, right? But in MCCQ1, you will definitely get a lot of cases out of these movement disorder. When it comes to neurology, you will definitely get case from these either Parkinson, probably from all of them, Parkinsonism, dystonia, Cori, myoclonus, and TIC or Tourette syndrome. So basal ganglia function, this is the main place for controlling the movement. So whatever happens here will affect the movement. So basically, let's start it from here. The core function is this area, and the motor pathway is direct pathway, indirect pathway. The main effect facilitate the movement, direct, and indirect is suppressing the unwanted movement. For example, if it is tremor, it is not supposed to be there, so indirect pathway will suppress it. But the direct is facilitating the movement, like walking, moving, posturing, doing body language, turning, all this. It is what you want and it will facilitate for you. But there are some movements that can come which are not supposed to be in a normal person, so the indirect pathway is suppressing them. So for all the movement, the hormone that plays the major role is dopamine. So the dopamine is the hero of this lecture. What does dopamine do? Dopamine is stimulating the direct pathway, so it is facilitating the actual regular movement, so it is supporting it. But dopamine is suppressing the unwanted movement, the irregular movement, or abnormal movement directly from indirect pathway. So they might ask you a question that which one of these following hormone is playing a major role in normal movement of this person or abnormal movement of this person. It will be dopamine. And probably they will ask what is the functionality of dopamine in controlling the movement. It will stimulate the direct pathway and suppress the indirect pathway. Learning objective, differentiation, use, recognition, suspect, identify, and apply. So basically, we have to be able to differentiate between different abnormal movement that they are going to be tested or asked you in the licensing exam. So we should be able to differentiate them and use pattern-based approach for every single one of them, especially the tremor, recognize Parkinsonism disease clinically, and identify a classic trap feature, suspect atypical Parkinsonism, which I don't want to insist more on that because they're not going to ask you anything that's more atypical or rarely happening. They're mostly focusing an exam on something that is very, very common or something that's very actually recent cases has been seen, or it is starting to get serious. So they're not focusing more on something that you might not deal with it in years of your practice. Okay. Identify the hallmark feature of the Huntington disease, dystonia, and Tourette syndrome. Apply high yield. MCQ1. So terms, what is akathisia? So they probably give you a scenario and ask you, what is this term called? So subjective generalized restlessness relieved by repetitive voluntary movement. Remember that when it comes to restlessness, two things might be in the option. One, akathisia, one, restless leg syndrome. Restless leg syndrome and akathisia, both of them are restless. But restless leg syndrome, if you notice, it has restless leg syndrome. So it's mainly lower limb. Mainly lower limb. And mainly it happens at night. Mainly it happens when you lie down. Mainly it happens during sleep. Akathisia, it can happen anywhere. So it's generalized restless. Okay, it can happen anywhere, and it's a generalized feeling of restlessness that the patient will start walking just to get some relief or suppress it. Astraxis is also called flapping tremor, transient loss of tone, and negative myoclonus. Astraxis negative myoclonus strongly suggests a metabolic encephalopathy, hepatic failure, uremia, and hypercapnia. So astraxis is also some sort of, we call it tremor, flapping tremor or astraxis. So you ask the patient to close his eyes and hold his hand, holding it like this, like this. And then the patient will start doing this movement, which is a myoclonus movement, right? So myoclonus movement, which it looks like a tremor. That's why they call it flapping tremor, because it is flapping. And it is actually also called astraxis. Now, this condition, we do it if you're doing a NACOSCI, you need to do it on your patient in order to rule out hepatic encephalopathy. If you're suspecting the patient may have liver cirrhosis, hepatic encephalopathy, hepatic failure, uremia, hypercapnia. So in these conditions, you need to do this test. Atetosis, slow rhythm movement, especially in distal limbs. Balism, large amplitude finding movement, usually unilateral, or hemibalismus. Bradykinesia, slow and a small amplitude movement, core feature of the Parkinsonism. So bradykinesia is the slowness of the movement in general. To make it very simple, bradykinesia is the slowness movement of the entire functionality of a person, whether it is writing, whether it is walking, whether it is speaking, whatever it is, everything gets slow. So bradykinesia is the hallmark of Parkinsonism. It means if a patient does not have bradykinesia, he doesn't have Parkinsonism. In order to have Parkinsonism, the patient should have bradykinesia. So bradykinesia is a must present feature of Parkinsonism. Then on top of bradykinesia, you need to have either tremor, rigidity, or balance issue. But bradykinesia has to be there. That is a core feature of Parkinsonism. If you don't have bradykinesia, you don't have Parkinsonism. You have to reconsider the diagnosis. Okay? Very important. That's why I made it red. Dyskinesia is an involuntary movement, often refers to tardive or levodopa-induced movement. Dystonia, co-contraction of agonist and antagonist muscle causing twisting posture or movement, and abnormal sustained posture occurring only during writing or another skill activity. So for the skill activity, it is called task-specific dystonia. For example, if it happens during playing guitar, so it's specific to playing guitar. That's why it's called task-specific dystonia. But dystonia usually happens in this area, in the neck area. That's called cervical dystonia, which is very, very characteristic finding of the extrapyramidal symptoms as a side effect of medication like antipsychotic medication. Okay? But if it is happening on certain part of the body and certain specific function, that's called task-specific dystonia. For example, you're writing and then your hands start moving like this or like this. So this is writing related dystonia. That makes it task-specific dystonia. Okay. Another characteristic of dystonia, that dystonia has a specific touch-sensitive test. Like the patient has dystonia like this, it is doing like this. And when you touch the face, then the dystonic reaction will stop right away. And it supports the diagnosis. Okay? Freezing. Freezing is episode of halted motor action, classically during gait initiation in Parkinson's disease. So it's very common to be seen in Parkinsonism. Like if you are doing a neck auscultation and you're dealing with a Parkinson's patient, once you ask the patient to give you a walk test, you need to comment on these findings. For example, shuffling gait, turning, arm swing, freezing. All this has to be commented on. You can't just look at the patient and say nothing. You need to comment. Like the patient with Parkinsonism, they have hesitance to start walking. Like they want to walk, but they can't. For some reason, they're stuck. And then they start walking slowly. This is called freezing. And myoclonus is brief shock-like muscle contraction, focal or segmental or generalized, can be triggered. Remember, myoclonus can be triggered by sound, touch, movement, or visual threat. Okay? By sound, touch, movement, or visual threat. Stereotypies, this is predictable, repetitive, purposeless movement, often associated with autism and intellectual disability. I don't know if you guys have seen people with the autistic spectrum disorder. Some of them, they are watching, let's say, their phone, and suddenly they put their phone and start running. It is purposeless running for no reason. They just start running, keep on running for maybe a few seconds to 1-2 minutes, and then they stop. This is an urge that they get. In order to get relieved those urge, they have to move and run, and they come back and sit. And there's no, if you ask them, why did you do that? They have no reason for it. It's purposeless movement. And it's more common in two types of condition. One is autistic spectrum disorder, intellectual disability. Tic, brief stereotype, suppressible motor or vocal action driven by an inner urge. It's like, you know, like when you have an OCD, you have an urge for doing something and then you do it. So tic is the same thing, except for tic, you have either motor or you have vocal. For example, tic could be as simple as this, as simple as this. Or tic could be just winking, like this. It could be tic. Or just saying something, anything, or making just voice. For no reason, you're clearing your throat. So, or making a voice. So it could be either or. It could be either or. Another thing about tic, which is very important, it's less than 12 months. But if it is more than 12 months and the patient has motor abnormality plus at least one vocal, then it is Tourette syndrome. Less than 1 year, tic, more than 1 year, Tourette. less than 1 year, either motor or vocal tic. After 1 year, motors, a few motor plus at least one vocal tourette. Now, tremor. Tremor is a rhythmic involuntary movement from alternating muscle contraction. So you know what is this. You have seen different types of it. Approach to a tremor, separate rest, posture, and intention tremor first. So for these different types, which commonly these are the ones that are being tested, whether you're doing MCQ or NAC-OSCE, especially in NAC-OSCE, you have to know how to do and perform all these three on your patient. So you need to know them. But in MCQ1, they might ask you that which one of these tremors is predominant in this specific condition. For example, in Parkinsonism, resting tremor is more common. For example, for beta-2 agonist or hyperthyroidism, the postural will be more common. For any ataxia or cerebral damage or injury, then the kinetic will be affected. So, type, resting. What kind of a tremor is resting? It's like a pill rolling tremor, better with action. Like when the patient is talking, moving, drinking and stuff, the patient doesn't have tremor, but when the patient rests, it starts. Another thing about resting tremor, that it mostly starts on a dominant hand. If you're right-handed, it will start with right hand. If you're left-handed, it will start with the left-handed. So it depends on, are you righty or lefty, then it will affect that side. But mostly, you know, like most of the people are right-handed, so it starts from the right hand. But it doesn't mean that it's going to stay on right hand. It will affect the left hand as well, but it will start with the dominant side. What else? Okay, so it's seen in Parkinson's disease, Parkinsonism, and Wilson's disease. Treat the cause, the Parkinson's disease, the response to dopaminergic therapy. So the best thing to do for Parkinson's disease in order to control the tremor is levodopa-carbidopa. Levodopa-carbidopa is not only helping you with other condition, other problem the patient has, it helps with the tremor. But remember that if the patient with Parkinsonism is young, then you use a different medication, which I'm going to talk about it. Postural, arm outstretched, fine tremor. So you ask the patient to do this. For this one, if you're doing NAC-OSCE, when you ask your patient to stretch his hand, you need to ask your patient to copy you. So can you copy me, please? Stretch your hand all the way and hold it like this. So that's why it's called posture, because the patient has to hold a specific posture, which is like this. And then the patient will start having a posture tremor. If the patient has hyperthyroidism, or if the patient has a beta-2 agonist toxicity. Essential common causes, essential physiological hyperthyroid and withdrawal. Beta-2, remember, if you're dealing with the asthma patient, if you're dealing with COPD patient, they're usually using the beta-2 agonist medication. Please remember to cover this in NAC-OSCE. Okay, essential tremor, propranolol, and primidone. But the best medication for this is going to be propranolol. So if I'm not mistaken, for the Parkinson's disease, I know levodopa-carbidopa, but for the younger patient with a tremor, I think it's trihexyphenidyl, if I'm not mistaken, but I will check it out. Intention, worst approaching target, cerebral disease. So intention is usually for the kinetic tremor, or for the intention tremor, always the main location for the balance, if it is affected, like the patient that cannot balance himself, which, and for example, in Parkinsonism, that would be one of the case. you need to do the kinetic test. Or if the balance is the issue that you need to address it, then you need to do this for the upper limb and heel to shin test for the lower limb balance or ataxia. Worst approach, cerebral disease, multiple sclerosis, Wilson disease, and drugs. Treat underlying cerebral causes. So this is the resting, this is the posture, and this is the kinetic or intention tremor. First, in a patient younger than 45, think about the thyroid TSH. If the patient has tremor, the patient is young, always we check for the hyperthyroidism, TSH, ceruloplasmin for Wilson, and brain imaging when the pattern is atypical or cerebral, we have to do an imaging to rule out the cerebral damage. Alcohol clue, alcohol often improves essential tremor, but it does not improve the resting tremor of the Parkinsonism. So for the postural, it will help. But we don't recommend our patient to go drink alcohol, okay? It is supportive if the patient says that, oh yeah, when I drink alcohol, it gets better. So we know what type of tremor are we dealing with, okay? Now, chore and myoclonus. Definition, it's brief, irregular, unpredictable movement that seems to flow from one part of the body to another. Like the way I did last night, right? So it's like a movement that starts from one part of your body and goes to the next. Common cause could be Huntington disease, levodopa-induced dyskinesia, Wilson, systemic lupus erythematosus, vascular disease, Sydenham-Corey, which is the most important reason, pregnancy Corey. High yield clues, most common cause of the Corey is in practice is the drug trap for Parkinson's disease. So if the patient is developing Corey and the patient has the Parkinsonism, remember that the levodopa and carbidopa are causing the Corey. Balism, hemibalismus is usually vascular and is more violent, flinching from the Corey. So it's very violent form of Corey, which is related to vascular issue, like stroke, like hypertension, and any other vascular issues, okay? So remember vascular because they might ask you this, and the violent type of Corey. Myoclonus is brief shock-like contraction that may be focal, segmental, or generalized. Types could be physiologic, like a hiccup, sleep start, essential epileptic, or symptomatic. Symptomatic cause could be metabolic disturbance, drug intoxication, withdrawal, hypoxia, infection, could be stroke, mass lesion, degenerative disease. Exam clue, myoclonus may be stimulate sensitive. So usually this will happen after noise, light, movement, or pinprick exposure. So this is the picture that we have for the Corey and also myoclonus. Corey waltz. So the cause for the Corey, there's a mnemonic which is Corey waltz. I think you guys have it in your note. So Corey gravidum, which is called pregnancy, Huntington disease, old stroke or a stroke, rheumatic fever, which is Sydenham-Corey, which is the most common after the levodopa carbidopa use, antiphospholipid and antibody syndrome, Wilson disease, autoimmune, levodopa-induced dyskinesia, tardive dyskinesia, and Sydenham-Corey. Myoclonus trigger is LMNTV. L is light exposure, M is movement exposure, N is noise exposure, T is touch exposure, and V is visual threat. That's why it's called LMNTV. Myoclonus mnemonic, I think we did talk about this. Oh no, that was Corey, sorry. So this is called cat hands. And for the Cortez, we have Cortez. Okay, cat hands is Cortez Jacob's disease, U, uremia, D, drug toxicity or withdrawal, H, hypoxemia, hepatic encephalopathy, epilepsy, electrolyte imbalance, neurodegenerative disorder, and S, stroke or head trauma. This is for the myoclonus. But what triggers the myoclonus is MNLTV, Curtis, cognitive decline, rapid progression, extrapyramidal signs, unsteady gait, twitches, stimulus sensitivity myoclonus, and zero recovery progression fatal. So Curtis is cognitive decline, rapid progression, which I told you that it will be within weeks and months, right? And extrapyramidal symptoms, the patient will have unsteady gait, ataxia, and twitches, myoclonus. Dystonia. So this is how the cervical dystonia will be. This is how the writing, and this is called sensory trick or touching the face, and the dystonia will disappear. So for typical forms, cervical dystonia, blepharism, writer cramps, task-specific dystonia, the pattern clue may be sustained or intermittent and can get worse with fatigue, stress, or emotion. Sensory trick, when you touch the face or neck, may transiently improve the symptoms. Progression clue, young onset. So dystonia usually happen in younger patient, or leg dystonia, more likely to become generalized. Treatment, if it is local, remember the best, this is something that they will definitely test you on. They gave you a scenario about dystonia, but it's local dystonia. For the local dystonia, you need to use botulinum toxin. For the local botulinum toxin, but for the generalized, if it is generalized, use benzodiazepine. Baclofen, dopamine. So benzodiazepine is also used, but we have another very benztropine. We use that as well, which is very commonly used for the systemic option, including anticholinergic, benztropine, baclofen, benzodiazepine, tetrabenazine, dopamine, and dopamine responsive and dopamine responsive dystonia. So this is dystonia, everything you need to know about. So this is the cervical. This is blepharism, forced involuntary eye closure, like this one. So it's called blepharospasm. This is for mandibular. This is task specific, generalized tonic, the generalized dystonia, trunk plus multiple body. So for this, you need to use the medication, systemic medication. For the focal, it's one body, segmental, adjacent region, multifocal, non-adjacent, generalized trunk plus at least two other region, hemidystonia, one side, considered structural lesion. If it is one side, it is usually the structural lesion affected. So when you touch like this, the patient gets better. What else here important? Okay, so let's go through this case. A 45-year-old develops painful involuntary turning of the head to the right, like this. The posture worsens with the stress and briefly improves when the patient lightly touch the chin. Neurological examination is otherwise normal. Most likely is cervical dystonia. Best symptomatic treatment, target botulinum neurotoxin injection. Yeah, there's nothing else. Individual oral therapy may include trihexyphenidyl, baclofen, clonazepam, levodopa, appropriate, severe movement disorder, globus pallidum, deep brain stimulation that is used for the Parkinsonism as well. Trihexyphenidyl, this one is used for the tremor in younger patient when they have Parkinsonism. All right, tick disorder and Tourette syndrome, the triad to remember. Premonitory urge, suppressibility, wax and wane. So the definition, sudden, rapid, recurrent, non-rhythmic motor or vocal movement. So either it is motor or vocal for the tick. Key clue, ticks are suppressible, often preceded by an inner urge and wax and wane. Tourette, multiple motor. Remember, for the tick, we have either motor or vocal. For Tourette, we have multiple motor, at least one vocal. And the timing for the tick is less than 1 year old, but for the patient with the Tourette is more than 1 year old. All right, so the Tourette multiple motor plus at least one vocal for more than 1 year with onset before age 18, associated with attention deficit hyperactivity disorder, OCD, rage episodes, sleep problem, and learning difficulties. Treatment with mild cases needs educational behavior therapy. Severe tics may need guanfacine or clonidine, antipsychotic, botulinum toxin, topiramate, or DBS. Now, tic and Tourette. So sudden, rapid, recurrent, non-rhythmic movement or vocalization. Motor example, eye blinking, facial grimace, shoulder shrugging, head jerking. Vocal example, throat clearing, sniffing, grunting. Typical clues, brief suppression. So we did talk about provincial, tic disorder, motor, and or vocal tics present for less than 1 year or less than 12 months. Persistent motor or vocal tic disorder, motor or vocal tics, but not both for more than 1 year. Remember, for the tic, it's either the motor or the vocal, but less than 12 months. For Tourette, it is multiple motor, at least one vocal, present at the same time, persistent for more than 1 year, first tic onset, and onset is less than 18 years of age, not explained by substance or any other medical condition. Common comorbid, remember, it is ADHD, OCD, and usually we don't start the treatment for this condition unless the patient has, unless the other treatment has been exhausted or the patient has Tourette plus attention deficit hyperactivity disorder, or Tourette with OCD, or Tourette with learning disorder, or Tourette with anxiety. So when it's a combo of Tourette with other condition, then we start clonidine or guanfacine. Coprolalia. Coprolalia is use profanity, using bad language. So this is not very common, as sometimes we see some clips that the people are using profanity and they're using bad language, but it is not required. It can be part of it, is part of it, but it's not very common and it's not required for the diagnosis. Okay. Okay. Minimal impairment, bothersome functionality. So the CBIT, this is important. This is important treatment or the first best treatment unless the patient has persistent or has combo of this condition with ADHD, OCD, anxiety, then we start the clonidine or guanfacine. So for the tic, a 9-year-old has eye blinking, so it is only motor, okay? For 4 months, so less than 12 months, 9-year-old only blinking for 4 months, which is less than 12 months, and no vocal tic, so it is only motor. Function is normal. So what is this? It is tic, provincial motor tic, reassurance and monitor. So for this, we don't do any treatment. Now you have another case, which is 12 years old, has blinking, shoulder shrugging, and plus throat clearing for at least 18 months. Now I have 2 motor, 1 vocal, and it is more than 12 months. and the patient is less than 18 years of age. So it is Tourette syndrome. I hope it makes sense. For tic, it is either motor or just vocal, less than 12 months. For the Tourette, it's multiple motor. It could be 2, 3, 4, 5, 6. It doesn't matter. It's more than one. More than one motor, but at least one vocal for more than 12 months. Parkinson's disease core clinical picture is TRAP. Remember, this TRAP is not my mnemonic. It has been there for a very long period of time. So TRAP, I love this mnemonic. It's the best mnemonic that you can remember about Parkinsonism. T stands for tremor. This T stands for tremor. The tremor is resting tremor. R stands for rigidity. And what kind of rigidity the patient will have? Cogwheel rigidity. And it looks like this, cogwheel. So it means when you ask the patient to, which we are going to do it in the Nakoski, when you're trying to open the patient's hand, it will be like this, like cogwheel. You can't do this, and it's not like spastic like this. It is like level by level, like this. And both sides, it's not directional dependent. So it could be the flexion of the joint, and it could be extension of the joint. So in both way, if you open the hand, it will have this rigidity. And when you do this way, also the patient will have rigidity, but it will be level by level. That's why it's called cogwheel rigidity. And bradykinesia. Bradykinesia is the slowness of the movement and all functionality of the patient. And postural instability. And the reason the picture is like this, because the only special test for the balance that you can do is called pull test. You pull the patient toward yourself and the patient will lose the balance, and you have to be able to hold the patient before the patient hits the ground. And substantia nigra, dopamine loss, please remember this. They may ask you as which part of the brain is affected, substantia nigra, or what is the main hormone affected in this condition, which is going to be dopamine. And shuffling gait. So TRAP, I mentioned it. Diagnostic, you do need the bradykinesia. So if you don't have bradykinesia, you don't have Parkinson's. With bradykinesia, you need either resting tremor, rigidity, or postural imbalance. Pattern, it is asymmetric, so it starts with one side, with your dominant side, and then it will become symmetric. Other motor clue could be hypomimia, hypophonia, monotonous speech, micrographia, shuffle gait, decreased arm swing, and freezing. So these are the things that you have to address while you're doing the physical examination of the Parkinson's patient. Important note, postural instability is usually a late finding in an idiopathic Parkinson's disease. Coriform movement occurs when levodopa effects is maximal or peak dose dyskinesia. So one of the chorea that happens, one of the most common reason is levodopa carbidopa. So Parkinson's disease, non-motor feature. There are some other conditions that they have nothing to do with the movement, but they are going to be present. So we need to be able to recognize them and know that they are also going to be positive. So the important note, non-motor feature could be autonomic, like constipation, urinary urgency, frequency sexual dysfunction, orthostatic hypotension. Psychiatric cognition could be depression, anxiety, slow thinking, dementia, and later stage, remember, sleep, REM, sleep behavior disorder, which is going to be also positive, and Lewy body with dementia, because the Parkinson is going to be present in that patient, right? Hypersomnolence. And then the treatment, mainstay of treatment is levodopa carbidopa or levodopa benserazide. But levodopa carbidopa is by far the best first choice. Early Parkinson's disease option, levodopa dopamine agonist, amantadine, monoamino oxidase inhibitor. Adjunct could be dopamine agonist, monoamino oxidase inhibitors, COMT inhibitors, and anticholinergic if tremor predominant. Complications, delay on the wearing off, random on off oscillation, and dyskinesia. Major adverse effect of the levodopa. Psychiatric symptom, if the patient has depression with the Parkinson's disease, the same thing. Like for the Alzheimer with depression, we were using the SSRI. For Parkinson's disease with depression, we are using the SSRI. Example, dopamine agonist, the pro, fear motor complications such as dyskinesia and dystonia. Cons, poorer symptom control and more hallucination, dizziness, constipation compared with levodopa. So we try not to use this a lot because the chances of developing hallucination, dizziness, constipation compared to levodopa is higher, but it has fewer motor complications such as dyskinesia or dystonia. But if the patient is very sensitive, like your patient has Parkinson's disease, and the patient, as soon as you start the levodopa, the patient gets dystonic. So in that case, you have no choice but to start the dopamine agonist, but you have to watch for that hallucination, dizziness, constipation, which is already there. So they are going to start getting worse and worse. So Parkinson's disease algorithm, how we can go about it. The motor symptoms affect function or quality. So levodopa is always the best choice. And then dopamine agonist and monoamino oxidase inhibitor would be the third choice. Again, levodopa carbidopa is the best choice for controlling the tremor. Not only that, the rigidity, the balance, the bradykinesia, everything. But if the patient is young, which normally doesn't happen, Parkinsonism usually tends to happen in elderly, like above 60, 65. But if it happens less than that, in a younger patient, the patient has tremor, then try hexafenadil. Oh, I have it here. Try hexafenadil, benztropine, rarely disabling, rarely disabling tremor in younger. Here we go. So it rarely happens because Parkinson is commonly not seen in younger patient. That's why it's very rare. But if it happens, remember that trihexafenadil will be the better choice. Example, a 42-year-old has medication-resistant tremor and TAC combination and no urinary or eye disease. A caution trial may be considered. Avoid an older adult, cognitive impairment, urinary retention, or narrow angle glaucoma. So something that to keep in mind that trihexafenadil, if the patient is younger and the cognition is there, the patient doesn't have urinary retention, then you can use this. So these are the short notes, and I'm pretty sure that you guys will be given the chance to go through them. Huntington disease, usually it happens at the younger age, between 35, 44. Genetic, it is autosomal dominant HTT mutation with a CAG. So remember that it's autosomal dominant. This might be asked. Typical onset is mid half-life, so relatively younger than any other conditions, which is 35, 45, or 44. Clinical trial is chorea, psychiatric changes, and progressive cognitive decline. Course, clumsiness and irritability progress to major neurocognitive disorder, psychosis, more obvious chorea, late disease may become rigid dystonic. Juvenile West fail variant is Parkinsonism, dystonia, rigidity, and seizure in somebody who is less than 20 years of age. Okay, so if the patient has these condition and less than 20 years of age, because we say that Huntington disease usually happens in young, 35, 45, like in this window of 9 to 10 years, right? 35 to 44 or 45, which is 9 to 10 years. But if happens in the younger age, younger than 35, like less than 20 years of age, and the patient not only have that, the patient has Parkinsonism, dystonia, rigidity, and seizure, then it will be juvenile Westphal variant. Treatment, no disease-modifying therapy, tetrabenazine, amantadine, and neuroleptics for CORE, for the and for antidepressant for depending on the condition, antipsychotic for the psychiatric symptoms, because the patient will have psychiatric symptoms, right? Depending on what the patient has, you decide whether you are choosing the antidepressant or antipsychotic. But tetrabenazine has been there in many subscriptions. So if you're being tested, you will definitely be tested on autosomal dominant. They will ask you what kind of condition it is, autosomal dominant, younger age, and the clinical trial. You have to know it. And then the best initial treatment, which is going to be tetrabenazine. Okay, remember this. Now, investigation and focus workup. Choose test that matches the movement pattern and the red flag. For tremor, young patient, less than 45, what do? Check for the seroplasmin, check for the hyperthyroidism, and consider CT and MRI if cerebral or atypical, or if the patient has ataxia with it too. Essential tremor, often clinical diagnosed, treat only the functionally significant. So we don't treat if it is not functionally significant. CORE, look for the causes. What caused the CORE? Was it the medication? Is it the Wilson disease, autoimmune, pregnancy, stroke, or HD? Remember, the levodopa-induced dyskinesia is very common clue. So if it is levodopa, you need to change it. Parkinson's disease, diagnosed mainly clinical, investigate more if atypical feature are present or secondary cause are suspected. Dystonia, check for the drug, toxin exposure, stroke, tumor, demyelination, Wilson disease, and Parkinson's disorder. Example, task-specific dystonia is classic in the writer and musician. So task-specific, it doesn't have to be writer, it doesn't have to be musician, but in these two profession, it has been seen a lot comparing to other professions. Okay, tic and Tourette. So the urge, suppressibility, duration, and their combo or their association with the ADHD and OCD comorbidities. Secondary cause, encephalitis, the Jacobs, stimulants, levodopa, head trauma. Huntington, confirmed with the genetic testing, imaging clue, caudate atrophy with the enlarged ventricle. So I really need you guys to remember this characteristic finding, like we did have it for the normal pressure hydrocephalus, we had it for the Alzheimer, and for Huntington disease also they might give you a scenario, and let's say they give you a scenario about somebody that who has psychotic, let's say depression, then the patient also have CORE, the patient also have imaging, and the imaging has been dementia, and also the imaging has shown caudate atrophy with the enlarged ventricle. So caudate atrophy with an enlarged ventricle should raise a suspicion about Huntington disease. MCQ1 high yield pairs, resting tremor in Parkinson's or Parkinsonism, intention cerebral disease, postural, right? Alcohol helps, suggest essential tremor, not Parkinson's disease. Hemibalismus is usually vascular. Sensory trick points toward dystonia. Like when you do this, the head dystonia results. Multiple motor plus vocal motor is Tourette, more than 1 year. Tic is less than 1 year, either motor or vocal, either this or that. Cortes, the mnemonic is the Cortes, progressive dementia, very rapid and progressive within weeks to months, ataxia and myoclonus. Myoclonus triggers is LMNTV, so light, movement, noise, touch, visual threat. 1 minute review of everything. Classify, match the syndrome, treat the big ones. So to classify, rhythmic, if it is rhythmic movement, tremor. Irregular flow movement, CORE. Twisting posture, dystonia. brief jerk, myoclonus. Suppressible repetitive action, tic. Trap, Parkinsonism. Majda syndrome, resting, bradykinesia is Parkinson's. Vertical gaze palsy, the PSP, which is a very atypical type of Parkinsonism you don't have to worry about. Autonomic failure is MSA, which is another atypical finding of the or condition of the Parkinsonism. Psychiatric plus Cure plus cognition, psychiatric Cure, dementia is Huntington disease. Sensory tract for dystonia. If you have a movement urge and vocal tic plus vocal tic for more than 1 year, Tourette. Treat the big ones. For the Parkinson's disease, the best treatment is levodopa carbidopa. Essential tremor, propranolol for propranolol or primidone if needed. Usually, we don't do it unless it is significantly affecting the patient's daily life. Then we start propranolol. Focal dystonia, botulinum toxin. The debilitating tics, behavior therapy, alpha-2 agonist or antipsychotic. HD or Huntington disease, Cure, tetrabenazine. Please remember this, tetrabenazine benazine is very commonly tested. So I think we did this. And thank you. Oh, that wasn't that long.